Thank you for your kind introduction. And I also want to thank the organizing committee for inviting me to talk about acute abdomen in neonates in the European Congress of Radiology. The author declares no conflicts of interest. As an introduction, it is important to point out that acute abdomen in neonates is a frequent emergency room challenge, that it's not limited to children's hospitals. Neonatal abdominal emergencies comprise a wide variety of conditions, congenital and acquired. Establishing the diagnosis of acute abdominal condition requires a high index of suspicions clinically and detection of subtle findings on imaging. Several imaging techniques are available for this purpose. Radiography, contrast studies, and ultrasound have major roles in evaluating this. CT and MRI may contribute to the diagnosis in certain situations. The main objectives of this lecture are to discuss and illustrate a practical approach to the acute abdomen in neonates, to review the most common conditions in which radiological evaluation contributes substantially to the diagnosis, to describe the radiological findings which may influence in clinical decisions, and to emphasize the radiological clues found in typical situations. When we face with an acute abdomen in a neonate, we may combine careful history with physical examination and then guide the correlative imaging. For this purpose, we have 4 statements, which are prenatal examination, clinical findings, perinatal condition, and familiar history. For example, if we are faced with a neonate who in prenatal ultrasound presented polyhydramnios, intestinal dilatation, or hyperechogenic meconium, and after birth presents with abdominal distensions, vomiting, or failure to pass meconium, a gastrointestinal obstruction should be suspected. Moreover, if there is a history of maternal diabetes, small left colon syndrome should be suspected, or if there is a history of cystic fibrosis, meconium should be the first option. Regarding gastrointestinal acute conditions, the most common clinical scenario in the acute abdomen is intestinal obstruction. Imaging of the gastrointestinal tract may be challenging. Abdominal radiography and contrast examination can provide the diagnosis, and ultrasound has come to play a significant role. Radiography is usually the first imaging technique. Obstructions occurring above the mid-ileum are referred to as high obstructions, whereas those involving the distal ileum and colon are low obstructions. This distinction in neonates is mandatory because 1, 2, or 3 dilated bowel loops are indicative of high gastrointestinal obstructions, and then radiography often suffices for the diagnosis. However, when more than 3 dilated bowel loops are seen, a low intestinal obstruction is suspected, and then contrast enema should be performed. Imaging intestinal obstruction is really challenging because interpreting the normal bowel and gas pattern is difficult. Differentiation between colon and small bowel and evaluation of distal gas may be difficult, as in this case of a newborn 8 hours after birth, where the entire colon is and a small bowel is full of gas. 3 hours after birth, the entire small bowel is user-filled, and it takes 8-9 hours after birth to see gas in the sigmoid colon. This is important in order to take the first image after these hours, if it is possible. Moreover, absence of abdominal gas may be due to mechanical ventilation or nasogastric aspiration. Delayed passage of gas may be due to traumatic injury, septicemia, hypoglycemia, or brain damage. In intestinal obstruction, distal bowel gas is usually absent. If present, is indicative of a partial obstruction. Radiography may determine the diagnosis, as in this case where there is a right inguinal hernia. Radiography also determines possible complications as bowel perforation. Please note this abdominal free gas in these locations. Regarding high gastrointestinal obstructions, 3 different cases are shown. The first one has a single bowel gas, and distal bowel gas is also present, which is indicative of an incomplete obstruction. The second one has the double bubble sign with distended stomach and duodenum, and absence of distal bowel gas, which is indicative of a complete obstruction. And the third one has the triple bubble sign, which is indicative of jejunal atresia, as we will see later on. Regarding gastric outlet obstruction, the clinical presentation includes persistent non-bilious vomiting, dehydration, weight loss, and hypochloremic metabolic alkalosis. The differential diagnosis include the hypertrophic pyloric stenosis, which will be addressed in the next session, antral web, and pyloric atresia, which is a rare atresia with good prognosis. This is a case of antral web. The ultrasonography was performed to rule out the hypertrophic pyloric stenosis and detected an echogenic band in the pylorus. The contrast examination detected the antral web. The second case was a duodenal obstruction. The clinical presentations include bilious or non-bilious vomiting, depending on the site of the obstruction related to the papilla. And the differential diagnosis includes duodenal atresia, as is seen in this case, or other obstructions like annular pancreas, such as annular pancreas, peritoneal fibrous band, duodenal web, preduodenal portal vein, or intraduodenal diverticulum. In duodenal atresia, the classic postnatal radiography presentation is that of the double bubble. Distal bowel gas is usually absent, and it may be associated with other congenital anomalies, such as cardiac anomalies, Bacter association, chromosomal anomalies. Up to 30% of infants have Down syndrome. In jejunal atresia, the third case we were analyzing before, the classic radiographic presentation is that of a triple bubble, where the stomach, duodenum, and jejunum are distended. Associated anomalies in gastrointestinal atresia include malrotation, volvulus, and gastrosclerosis. Please note in this case that the proximal jejunum has an abnormal course to the other side of the abdomen. This is a case of jejunal atresia with malrotation. Intestinal malrotation should be understood as a continuum of development errors reflecting a failure in rotation or fixation at any stage of the formation of the midgut. If the error fails to progress after 90 degrees, the duodenum lies on the right and the colon on the left, as seen in the first picture, in the first case. If the rotation fails to progress between the 90 and 270 degrees counterclockwise rotation, then the duodenojejunal junction is malpositioned. Diagnostic imaging of intestinal malrotation is challenging but extremely important, as it predisposes to volvulus, an acute life-threatening condition. The abnormal rotated bowel does not develop the normal mesenteric attachment, which is seen in the first picture. It has a narrow mesenteric, which predisposes and correlates with high risk of volvulus. Peritoneal lat bands, what is that? Sorry. Lat bands, I cannot point like this. Lat bands are peritoneal bands that try to attach this malpositioned bowel and often entrape the duodenum, as seen in the last case. Intestinal malrotation is present in the majority of patients with heterotaxis syndromes, as seen in this other neonate, where the liver is on the left, the stomach on the right, and there is a suspicious malrotation. Other associated anomalies include chromosomal anomalies, intestinal atresia, diaphragmatic hernia, gastroschisis, and omphalocele. This is a case of a neonate with an omphalocele and distended bowel loops. The CT previous to surgery revealed the liver, the gallbladder, and the bowel loops inside the omphalocele, and also the abnormal relation between the mesenteric vessels. But we have to look carefully for associated anomalies, in most of the cases more than one. And if we look carefully at the first radiography, we also see that there is a loop on the nasogastric tube indicating an esophageal atresia, which is also associated with malrotation. Imaging intestinal malrotation, radiography is usually the first imaging tool performed. It is performed in order to rule out other entities and to guide further imaging. Contrast gastrointestinal examination is the gold standard method. When malrotation is suspected and upper gastrointestinal contrast study is undetermined or difficult to interpret, ultrasound may add useful information. Also, contrast enema is helpful determining the second position. CT is not routinely performed in children in order to avoid radiation. The diagnosis is usually made with CT or MRI in a non-suspected patient or as an incidental finding. This is one of the cases we're looking and analyzing before, with a distended bowel loop in the upper right quadrant. The contrast examination shows the third portion of the duodenum distended and also with the loop here, and malrotation with a lat band was detected on surgery. Intestinal volvulus is an emergency. It's a surgical emergency. Most cases of volvulus in children with malrotation occurs usually the first month of life. Bowel obstruction with bilious vomiting is the classical clinical presentation. The intestine twists around the superior mesenteric artery, as seen in the first two images, obstructing lymphatic and venous drainage, as seen in the last one, and most of the cases arterial supply. This is a case with intestinal volvulus in which the radiography has an abnormal bowel gas pattern with distended bowel loops, and the contrast examination shows the abnormal course of the duodenum, and around this position the distended bowel loops on the right of the abdomen. Moving on to low intestinal obstructions, normal newborn pass meconium the first 24 hours of life. Non-passage of meconium or passage of little amounts of it suggests distal obstruction. Distal bowel obstruction causes abdominal distension and progresses over the first 48 hours. Further imagination in these cases is mandatory. The pattern of distal bowel obstruction on radiography is not specific. Therefore, contrast enema is recommended. 4 patterns have been described which offer a differential diagnosis and allow appropriate management decisions. The first one is microcolon. As seen in this image, a microcolon shows a small caliber, usually less than 1 centimeter. The most common causes of microcolon are meconium ileus and ileal atresia. The distinction is very important because uncomplicated meconium ileus can be treated with contrast enemas and ileal atresia requires surgery. This patient has meconium ileus. Look, the microcolon, please note the microcolon and also the meconium concretion on distal ileum. It is described as the early manifestation of cystic fibrosis. The contrast enema is therapeutic in most of the cases, and it may be complicated in about half of the cases by volvulus perforation or peritonitis. This other patient presented a complicated meconium ileus. Please note in the first image the concretions in the distended bowel loops, also the pneumoperitoneum. It progressed rapidly to extensive pneumoperitoneum and extensive dilatation of the bowel loops, and this patient requires surgery. Here we can see the correlation with the surgery with the concretions, the meconium concretions inside the distal ileum. This patient needed a resection of 7 centimeters. The second cause of microcolon is ileal atresia, which is the most common intestinal atresia. It is also associated with cystic fibrosis in up to 12% of the patients, and also with malrotation, volvulus, or gastroschisis. These patients present multiple bowel dilated loops indicating a low intestinal obstruction, and a microcolon was depicted in contrast examination with a stop near the distal ileum, and atresia was found in surgery. The second pattern is short microcolon, which is related to colonic atresia. Colonic atresia is relatively uncommon. It is typically located in the colon proximal to the splenic flexure. A pattern with short or incomplete microcolon is seen on enema. Occasionally, there may be a disproportionate distended loop that represents a blind or almost blind pouch of the colonic atresia, as seen in this case. Please note the absence of distal bowel gas, a huge dilatation of a bowel loop in the upper abdomen. Contrast examination shows a distal microcolon and then a very narrow communication with this pouch of the atresia. The third pattern is colonic caliber change. When colon caliber changes from a small or normal caliber colon distally to more dilated colon proximally, the differential diagnosis includes Hirschsprung disease, which must be treated surgically, and a small left colon syndrome, which usually resolves after contrast enema. There are two types of Hirschsprung disease: the short segment 1, which is seen in up to 75% of patients and it's located in the rectosigmoid colon, and the long segment disease, which is seen in up to 25% of patients. Associated anomalies are seen in 20% of patients, and meconium plaques may coexist in up to 30% of patients. Consequently, when a meconium plaque is seen, concurrent Hirschsprung disease should be investigated. The typical imaging findings on contrast enema are, as seen in the first image, an abnormal rectosigmoid ratio, a transition zone of the rectal narrowing, irregular contraction, and retained contrast material on delayed radiography. In some cases, findings in contrast enema may be subtle, as in this case with a low intestinal obstruction and a narrow here in the distal rectum. Therefore, in a newborn with clinical signs and symptoms strongly suggesting Hirschsprung disease, rectal biopsy is required for a definitive diagnosis if contrast enema is subtle or normal. The second cause of colonic caliber change is a small left colon syndrome. It is a benign and self-limited transient functional colonic obstructions. Infants of diabetic mothers or of mothers who receive magnesium sulfate for preeclampsia have a high incidence, and the images is seen like this case with concretions inside the colon. The fourth pattern is normal contrast enema. It may be seen in functional obstruction of prematurity and sepsis, but also in mid-gut volvulus, in congenital hernia, or in Hirschsprung disease. That's why a normal contrast enema in a clinical and radiological setting of lower intestinal obstruction should not be reassuring. Moving on now to another clinical situation, if the neonate presents with abdominal distension and failure to pass meconium and also has a perineal anomaly, anorectal malformation should be suspected. Moreover, if there is a cystic pelvic mass on ultrasonography, a cloacal malformation should be suspected, and also if there are other anomalies, a Vactor association should be investigated. The classic diagnosis of anorectal malformation starts with the inspection of the perineum. Anorectal malformations include complex anatomical malformation, which range from imperforated anus to cloacal malformation. The diagnostic approach includes a lot of imaging technique. The first one in postnatal diagnosis is abdominal and transperineal ultrasound. They identify the distal rectal pouch, suspect fistulas, and detect associated anomalies. Imperforated anus, also known as anal atresia, is usually recognized at birth, and an ultrasound transperineal access is performed the first day of life. The anatomical description of the common channel and fistula are useful to decide the therapeutic approach. As we can see in this image, the bladder neck, the urethra, the anal channel, and also the rectal pouch. We can measure the distance between the rectal pouch and the skin. This is another case in which, during the first image, we may suspect an recto-urinary fistula because there are a lot of bubbles in the urethra. Also, the big morphology of the rectal pouch suggests this. Contrast examination through colostomy depicts the fistula, and also cystography depicts the exact location of the fistula. Cloacal malformation are the most complex ones. Cloacal malformation are rare congenital anomalies in which the urinary tract, the vagina, and the rectum converge in a common channel. It can lead to bladder obstruction, hydrometocolpos, and colonic dilatation. Children with cloacal malformation need urgent clinical and radiological evaluation the first day of life. They typically require a colostomy to avoid fecal contamination of urinary tract and renal complications. If we move on now to another clinical situation, if the patient presents abdominal distension and gastrointestinal bleeding, then a mecal diverticulum into suspension or vascular anomalies that may cause hepatic dysfunction or also congestive heart failure may be suspected, but we will focus on necrotizing enterocolitis, which is the most frequent one. It represents a significant cause of neonatal morbidity and mortality, especially in preterm infants. Imaging with radiography and ultrasound plays an important role in the diagnosis. Radiography is currently the modality of choice for imaging enterocolitis. Ultrasound have been found to correlate with prognosis. Consequently, therefore, ultrasound may be used for early detection of high-risk neonates who may benefit from more aggressive treatment, including surgery. This is a case of a preterm infant with pneumatosis, seen in the left colon. Also note that this portal venous gas here. Pneumatosis represents a pathognomonic sign of necrotizing enterocolitis. Portal venous gas may indicate progression but is not associated with surgical outcome. Pneumoperitoneum remains an absolute indication for surgery. An advantage of bowel ultrasound include the real-time assessment of peristalsis, perfusion, thickness of bowel wall, and abdominal fluid. This is a case of a neonate preterm infant with necrotizing enterocolitis in which there was a rapid progression to distended bowel loops of the pneumatosis intestinalis, and also there was an abnormal gas pattern here in the right iliac fossa. Ultrasound depicted a thin-walled bowel loops and also a destructurated bowel loop in the right iliac fossa. The second case is another preterm infant with pneumatosis and also pneumoperitoneal. This is the image correlation with surgery. This is the cecal appendix and a necrotic bowel loop with perforation. If we move on now to other neonates who present abdominal distension and ascites, then meconium peritonitis should be one of our diagnoses, suspicious diagnosis. And also if we palpate if there is a palpable mass, then we have to perform a broad differential diagnosis with cystic masses and solid tumors which may compromise the airway or the cardiovascular system, but in which we'll not focus on today. Meconium peritonitis is a chemical peritonitis caused by intrauterine bowel perforation. It may be idiopathic or have an underlying cause, and most of the cases resolve spontaneously and peritoneal calcifications are seen. These neonates present the typical image of ascites with bowel loops in the center of the abdomen, but also please note here there is a calcification in the right upper quadrant. This is the typical image in ultrasonography with a snowstorm appearance and calcification in the scrotum through the processus vaginalis. And to finish with the clinical presentation, if the patient presents abdominal distension, pain, it may be due to infection or sepsis, it may be due to traumatic injury or also to iatrogenia. Special attention should be put on the umbilical catheter in neonates. This patient presented hepatic dysfunction, coagulopathy, and ascites. The umbilical catheter was far introduced in the liver. There was a left portal main thrombosis with secondary arterialization and multiple masses, echogenic masses in the liver were of the extravasation of the parenteral nutrition. Also, we have to be careful when evaluating postoperative images. This is the first radiography after birth with a diaphragmatic hernia and a mediastinal shift. The patient went to the to surgery, and after that he presented an acute abdomen, and we saw a palpable mass which corresponds to the spleen in the right iliac fossa between the second, the ilium, without Doppler, and it corresponds to a volvulated wandering spleen. Before I reach my conclusion, I would like to encourage you to face with the neonatal abdominal emergencies, because we play a fundamental role in the diagnosis, awareness of the most common radiological emergencies and its association will guide radiological investigation, which may be crucial for prompt treatment. Remember that imaging findings are often subtle and high index of suspicion is needed, and also careful evaluation of the clinical history and meticulous image techniques will lead us to an accurate diagnosis. Thank you very much for your attention.